Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a male of 60 years of age, smoker without other cardiovascular risk factors or any background of interest. He was diagnosed by the emergency services as an ST segment elevation myocardial infarction of 4 hours of evolution, for which fibrinolysis was performed, and then he was brought to our center. At his arrival, his clinical situation was stable and without chest pain. This is the first electrocardiogram of our patient, the one that justified the diagnosis and the fibrinolysis. As you can see, it is evident that there are ventricular repolarization alterations. These alterations express as elevations or descents of the ST segment in some leads and suggest an acute myocardial lesion. Can you identify these alterations? That's it! In this electrocardiogram, we have an elevation of the ST on inferior leads, which are the leads 2, 3, and AVF. Moreover, we also have an elevation of the ST segment on V3 to V6 and a descent of the ST segment on AVL, V1, and V2. Also, an image of right bundle branch block must call our attention. We should remember that positive vectors in these leads could be the reflex of an area with necrosis in the posterior wall. In any case, we could say that the patient had an inferior and lateral STEMI, reasons for which, if primary angioplasty could not be guaranteed in a period of 90 minutes top, fibrinolysis was justified if there were no contraindications for it. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. To administer fibrinolysis, it is necessary to have an electrocardiographic control with the intention of evaluating the ST segment, because we can only suppose the treatment was effective when, after 90 minutes, the ST had descended less than 50% and chest pain disappears. In this case, as you can see, treatment was satisfactory because there are clinical and electrocardiographic criteria of coronary reperfusion. In this way, cardiac catheterization is preferably performed in the period of the next 24 hours, and as you can see, no significant coronary lesions exist in the left tree. Let's take a look at the right coronary tree. In this case, it is evident that the artery is open, which should not be surprising because the coronary reperfusion criteria were already depicted. However, the problem is not entirely solved because fibrinolysis only dissolves the thrombus but does not stabilize the plaque nor resolves the coronary stenosis, so an angioplasty is still necessary. First, we need to pass a guide wire through the lesion. In this case, the process was easier than in non-reperfused patients because we are able to see the distal bed of the blood vessel. Next, a drug-active stent is directly implanted. This props the artery and returns blood flow. Finally, after post-dilation with a non-compliant balloon of the proximal segment of the stent, a good angiographic result is achieved and without peri-procedure complications. This is how our case concludes, and with it, our chapter. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!